Assalamu alaikum and a very good afternoon. I'm Dr. Azhar Rahman on the behalf of PSA Karachi. So today we have a very interesting and very complex topic for discussion, that is the anesthesia for scoliosis surgery. The topic itself is very important, not only the intraoperative management, but also the postoperative pain and other management as well. So we have, for this topic, we have Dr. Jodat Saleem. He is the professor of anesthesia and critical care management. Uh, he is associated with the Postgraduate Medical Institute, Lahore General Hospital. He is a fellow of the year of 2000 with total working experience, not only in Pakistan, but abroad as well, that expands more than 25 years. He established the first ever ICU in Sahiwal at District Hospital. He established a state-of-the-art ICU in PGMI, Lahore General Hospital. He is the supervisor for anesthesia and critical care medicine as well. He is the executive member of MS Anesthesia at University UHS. Um, he is also working as a faculty of anesthesia at CPSP, Pakistan. He has more than 20 research peer-reviewed articles, and he also worked as the in charge at Lahore General Hospital in COVID ICU. So currently, he is working as the president of PSA Lahore chapter. So we welcome you, Dr. Jodat Saleem. So before we can proceed, may I request all the participants to please turn off their cell phone on the mute mode, their microphones. And if you have any question to ask, you can write down in the chat box. Um, Dr. Jodat, you can start now.
Thank you very much, Azhar, for the introduction. And I would like to first of all, I would like to thank the PSA Karachi and the organizing committee for inviting me for this talk. As you mentioned, this is one of the challenging experiences during anesthesia. If we talk about the scoliosis surgery and anesthesia. So my talk will going to be, we'll start with the scoliosis introduction and what are the statistics, and then we'll go through what are the different preoperative challenges which we have to keep in mind before we start the surgery. And then we'll go through the various examination system through the pre-op assessment preparation and what are the work we require for that. Then what are the intraoperative concerns, and then what is the specialized monitoring which we should carry out with this with the surgery, and then what are the different modalities in which a scoliosis patient is operated for the non-scoliotic surgery. And finally, I'm going to present a case report, which is the Russell-Silver syndrome. This is a rare syndrome, and I have come across this case for the very first time in my clinical experience. So I thought that it's worth to share this this case report with you people as well. So I'll try to, as this is a common, which is this is a topic which is commonly asked in the part 2 Vivas question, and particularly in the MS exit examination. So all the PGRs who are involved in this discussion, they are free to just to note down your queries, and in the end of the lecture, we'll try to interact and we'll try to cover your queries. And I'm starting with the topic right now. So what is scoliosis? Actually, this is a lengthy topic, so I'll just try to cover it first, and then we'll have an interactive session. So scoliosis, the Scoliosis Research Society defines scoliosis as a lateral curvature of the spine in an upright position. And the other definition is scoliosis as a lateral curvature of the spine of more than 10 degrees measured by the Cobb method on a standing radiograph. The scoliosis affect almost 2 to 3% of the population worldwide, and it should be separated, or it should be a different entity, which we call as kyphosis. Kyphosis is actually an abnormality of the anteroposterior diameter of the thoracic region. So the onset of the scoliosis can be at birth, and it could manifest in the children, in the childhood or early adolescence, and it is mostly evident between the ages of 10 to 15 years. So this is about the statistics, and it is more often found in the females as compared to the males. And the female requires surgical correction 8 times as compared to male. So this is a huge difference between the surgical requirement of a female and a male. This is the international statistics. If you talk about the causes of the scoliosis, it is congenital, then idiopathic, which is the most common cause, and it comes to about 70% of the cases. And again, in this, mostly females, and right side of the female is mostly involved. The non-idiopathic causes, they are generally the neuromuscular, traumatic, and different syndromes. So in neuromuscular, we have cerebral palsy, dysautonomia polymyelitis, and dystrophic myopathies and myotonia. Then in traumatic, it could be due to post-fractures, post-radiation, post-burn, and different thoracic surgical procedures. Then neurofibromatosis, and really in the Marfan syndrome. Now, how the Cobb's angle, which we generally know to measure the angle. So what is this? This is a measure of greater curvature of the spine. And what is the clinical significance of the Cobb's angle? So if angle is less than 10% of the normal curvature, it is considered as a normal. Angle of more than 10 is fall into the category of scoliosis. With an angle of more than 25 degrees, it leads to raise in the pulmonary artery pressure. Of angle of more than 40 degree, there are different books that state 40 to 45, some says 45 to 50, and some says more than 50. Then surgery is indicated along with the, if patient is clinically show you some certain features. Then angle of more than 65 degree, it leads to the restrictive lung disease. An angle of more than 100 degrees, it leads to severe pulmonary dysfunction along with the cardiac dysfunction. And one very important thing is that if we talk about the neuromuscular type, in which I mentioned previously certain in this slide. Patient with neuromuscular type, they have more profound decrease in the pulmonary function for any given curve. Like in idiopathic, with all these upper modalities, you will find these pulmonary function. But in a neuromuscular type, even if the angle is less than 40 degree, around 50 degree, you will have severe pulmonary or cardiac dysfunction. Now, how to measure Cobb angle? So there are different methods. Mostly the gold standard is the measurement on a chest X-ray radiograph for scoliosis. Now, what you do is you draw a line from the most. This is the line which you draw from here, and this is the deformity which is most obvious on the X-ray. And then you draw the second parallel line from this from the lower one. And then you draw two perpendicular lines from this line, like one perpendicular line, and from the other area, this perpendicular line. So this is the Cobb's angle. I will show you another diagram as well. So what are the limitation of the Cobb's angle? The limitation of the Cobb's angle are like if you have not been able to find like the deformity, if you go one vertebra up or one vertebra down, the Cobb angle will be miscalculated, and it leads to like it's more of an orthopedic concern because of their surgical correction and their how to manipulate these. And similarly, what they have found that at different points on the same X-ray, different people have calculated Cobb's angle in a different way. So what you can do is you can go for the 3D X-rays, MRI, or CT scan. There's another picture. Here you can see the perpendicular line from the two most deviated vertebrae, and then you draw one perpendicular line from this and one perpendicular line from this, and this is your Cobb's angle. They've calculated like 43 degrees. Now, spinal biomechanics. So in normal alignment, spinous processes are all lined up in a straight line over the sacrum. So this is the sacrum, and here you can see this is going in a straight line. But if you talk about the scoliosis, it has angular displacement as well as the lateral displacement. So here you can see this is the lateral displacement of the spine, but it is not angulated. But on the other hand, in this picture, you can see the spine is laterally displaced, as well as the vertebrae, they are placed at different angles. So this makes things more difficult and challenging for the surgeon as well as for the anesthetist. This is a picture of a 3D scan in which one side is convex and the other side is concave, and you can see how the deformity is present here. Now, coming to the anesthetic concerns and challenges, and what should be kept in mind before we proceed for a scoliotic surgery. So anticipated difficult airway, it could be due to two reasons. One is the anatomical variation in the spinal, in the vertebral column, and the other is the, at times, the patients have been placed a halotraction prehand. So with this traction in place, it is very difficult to manage the airway. Then the spine examination should be done before start of the scoliosis surgery. If it is, most of the time, it is right-sided convex. But if it is left-sided convex, it may lead to genitourinary dysfunction prehand. They may present with the cardiac anomalies in 20% of the cases, and they have 23% of the cases, they have spinal cord deformities as well. Then talking about the pre-operative optimization of the patient, and there are three aspects which we have to look for. Number one is the cardiac component, number two is the respiratory component, and number three is the nutritional component. So I'll start with the respiratory component. What happens that due to deformity of the rib cage, there is chronic changes in the lungs leading to hypoxemia, and secondary to hypoxemia, there's pulmonary hypertension, and ultimately there is right ventricular hypertrophy. And regarding cardiac, with right ventricular hypertrophy, there's again this right hypertrophy and right ventricular hypertrophy and pulmonary hypertension. It creates a lot of hassle for us to manage during the intraoperative period. And if it is associated with the Duchenne myotrophy, then it leads to cardiomyopathies as well. And along with this, if you talk about the nutritional status, somehow these patients are not very well nutritionally very well built up. So before you proceed for the surgery, to have a good outcome, you must correct their nutrition status, because it is never an emergency or emergent surgery. Then talking about the intraoperative concerns, so 90% of the surgeries, they are done in a prone position, and you'll have to use the nerve monitoring. And according to the habitus of the patient, you have to select how you're going to place your patient on a prone position. This I'm going to explain you in a later slide. And as it is a major surgery, at times 7 to 10 vertebrae are involved. So there is an anticipated massive hemorrhage. So you should be prepared for that. And then postoperative respiratory complication and prevention, because their chests are already compromised. And later on, after the major surgical intervention, they get complicated. They've got atelectasis, pneumonias, and chest infections. So this has to be taken care, and this patient should be placed in either an HDU or ICU. Now, what is our major concern? So our major concern is to prevent the neurological injury, and the different challenges which we have to face, or which we have to keep in mind, is the intubating challenges. We should get ready for the difficult airway, and how to maintain these patients. Generally, these patients are maintained on TIVA, and there are different options how we can do it. Then appropriate positioning, which is I'm going to discuss again. Reducing the perioperative blood loss, what are the different strategies, and reducing respiratory and cardiac complications, how to prepare them before surgery. And then adequate anesthesia is very important, because after such a massive incision, they should have a very good anesthesia to control the pain, so that their pulmonary reserves can improve, prevention of the infections, and monitoring intraoperatively and postoperative care. Regarding preoperative evaluation, so what? So you look for the cough, the symptom of the cough, sputum production, any recent infection, apart from the routine history. You should look about, you should be thinking about the shortness of breath, orthopnea, exercise tolerance, what are the meds of the patient, and in idiopathic cases, what are the associated comorbidities, and in a non-idiopathic patients, if you particularly talk about the CP child and Duchenne muscular dystrophy, and what are the features which could be associated with that. In CP child, exercise tolerance test management is difficult in the preoperative period. Secondly, they have low mental equation, and so they are not able to follow your demand. They generally have chest infection pre-hand, and they at times they have pneumonias. So you have to be very careful if you're dealing with a CP child. So its preparation in the preoperative period is very challenging, and similarly their postoperative course is quite rough. If you talk about the Duchenne muscular dystrophies, they are generally associated with the cardiomyopathies. Now coming to the airway examination, then assessment of the nutritional status, respiratory examination, and cardiovascular examination, neurological examination, and spine examination. So we'll have to take care of all these examinations in detail to get a good outcome. The two important, apart from your routine investigations, which we go like for complete blood count, grouping, cross-matching, and rest of the biochemistry, the two important tests regarding cardiac and respiratory are the pulmonary function test, and most of the time these patients present with the restrictive lung disease spectrum. So what you will find in decrease total lung capacity, decrease forced vital capacity, and they have lung parenchyma changes, or you will find interstitial lung disease, or then you have rigid chest wall and neuromuscular dystrophy as well. So your pulmonary function test will reveal a picture of the restrictive lung disease. Similarly, echocardiography is particularly important if you are dealing with a patient of a curve of more than 40 degrees. So you will have pulmonary features of the pulmonary hypertension and raised PA pressure. And mild pulmonary hypertension is 20 to 40, moderate is 41 to 50, and severe is more than 55. And as I mentioned earlier, that cardiomyopathy, if Duchenne muscular dystrophy is associated. And one important thing is that mitral valve prolapse may be present in 25% of the patient with this disease, with the disease of scoliosis. Now, how to manage these patients? It is not an emergent surgery. We can wait. We will have to look for the components which are reversible. We should optimize all these components. Like as I mentioned earlier, there's a element of chest infection, repeated chest infection in these patients. If there is asthma or pneumonia, it should be corrected pre-hand, because we are anticipating pulmonary atelectasis later on after these surgeries. So these factors should be kept in mind. Similarly, if you talk about the other two important is the nutritional status, cardiovascular optimization, and anemia should be corrected to pre-hand. They should be managed on the lines of the ERAs, and you can start with the preparation of the chest, like incentive spirometry, chest physiotherapy, so that their breathing exercises, so they may be able to breathe quite normal later on after the completion of the surgery. Then cardiac status, if they have hypertension, pulmonary hypertension, the element of the cardiomyopathy is there. So a cardiologist opinion should be obtained, and these factors should be optimized as much as we can before the surgery. And then the blood bank and preparation for the blood on the day of surgery, and ICU or HDU should be notified regarding the surgery and a booking of the bed in these certain areas. So there are different surgical approaches to scoliosis. The most common is the posterior spinal fusion with the contoured or adjustable rods for the younger children. Then there's an anterior approach through which the thoracoabdominal incision, and what they do is they just hemivertebral removal, or at times they do the discectomies. And the third is the combined posterior fusion and anterior leads with the endoscopic option, but it's generally a rare. It's generally done rarely. I haven't seen this thing in our center. Let me brief you about our center. We are dealing with a center where we are almost operating around 1,500 to 1,800 spine a year, and almost 50 to 60% of these spines, they are scoliotic patients. And so we are doing this for last 10, 12 years. To start with, when we started this surgery like 12, 13 years back, we used to do the wake-up test, and now we have, for the last many years, we have converted on the neuromonitoring, and we are dealing these cases with the neuromonitoring. So talking about the position, your almost 90-95% of these surgeries, they are done in the prone position. And as we all know that whenever we put a patient in a prone position, there are different setups where you make these positions. Like if you talk about, I'm also working in a neuro center as well. So in that area, when we go for prone position, what we do is we have wooden, they call as wooden chalkies, or just your wooden box, and there is a certain foam is over there, and these patients are just put on these in a prone position. If you talk about the center where I work privately, this is the Wilson frame, which they use. This is a padded frame, and it is adjustable, and it just fit into the contour of, according to the contour of the body. Then we have like big foam these blocks where we can adjust the patient, and we have a gel ring to adjust the neck and face of the patient, because what you have to take care is to take the protection of the eyes and adequate padding of the pressure points, particularly the genitals, the knees, and the abdomen should be clear, and the area between them, so that it can expand easily. Then particularly this position challenge due to the heavyweight patient who are like 100 kgs and above, it is really difficult to manage and make their position. Then importance of securing the endotracheal tube, because we just do it with the double end, like we go for the tape binding as well as the other binder. And then we use the intravenous line in prone position, how to secure them so that they are not get dislodged, because it's very difficult to put these lines once the patient is in a prone position. Then monitoring of the arterial line, central line, if you have placed it, or any other monitor if you're using it, and then the neuromonitoring. So regarding the intraoperative concerns, so the TIVA is the technique of choice. And why it is the technique of choice? It is because the muscle relaxant have to be avoided due to neuromonitoring. And if you use your anesthetic gases in more than 0.5 mg, it also affects the neuromonitoring. So that's why you'll have to rely on the technique TIVA. So it is going to be a close communication between the surgeon, between the anesthetist, and the person who is doing the neuromodulation and neuro navigation. So apart from your routine monitoring, which is standard A and 2 monitoring, but we go with generally, these are prolonged surgeries, so we go for a urine output, we go for central venous line at times, and arterial line, and T should be there, or if T is not there, LITCO or PICO should be a part of your monitoring if you're dealing with an angle of more than 65. Along with that, BIS, because in TIVA, ideally, BIS should be a mandatory component using with the TIVA. Then the somatosensory work potential and motor work potential and EMGs, they all should be this is generally a part which is taken by the neuro navigation team. So why we are so worried about the this specialized monitoring or neuro monitoring? Because what happens that the surgeon, they are operating near the vital nerve structures. So whenever they reach that area, there's a quick identification with the nerve signal, and the nerve signals are disrupted on the neuromonitor. And immediately the neuromonitoring team, they inform the surgeons, and they just they protect the nerve integrity, and they're careful, and they are just apart from that area where nerve is emerging. So that's how they basically preserve the neurofunction later on. This is the picture of where I work, and this is a BIS monitoring. And we generally kept it between 45 to 60. And this is how this is applied.
We put the code into the template. So this is we have put it into the frontal lobe, and the right one is on the one motor cortex for the right MEP. Put on the right motor cortex, and the blue one is on the left motor cortex for the left MEP. And now this is for the right sensory cortex for the right SCP, somatosensory lobe section. And the black one is on the left sensory cortex for the left sensory lobe section. And then this is on the occipital lobe for the EEG purpose. On gray, we put like
Now this is another one.
कैथोड होगा, ये एनोड होगा। ठीक है, अपूर्ण कराना है आप। ठीक है, डार्क इज कैथोड एंड लाइट इज एनोड। ये है हम लगाने हैं टीबीएलएस इंटीरियर। Extensor hemisphere process. Extensor hemisphere brevis, cathode and anode. And this is for posterior tibial nerve. And this is for sensory one.
No, evoke potential. What it does is, as I mentioned you earlier, that the surgeons are working in the close proximity of the nerve root, so they just as the signal gets down, they just get more careful and to handle the area where the nerves are emerging. So somatosensory work potential measures signals from the somatosensory cortex, whereas the motor work potential measures the signal from the motor cortex to the target muscles. So continuous assessment that allows the real-time adjustment with the surgical teams. That's diaphragm, that's a peripheral nerve, and it's from this peripheral nerve, the signals go to cervicomedullary junction, and from this to the thalamus, and finally to the sensory cortex. And these are the waveforms which are going on in different areas. And as there is some disruption in these areas, the neuronavigation team, they immediately inform the surgical team, and they are careful. Similarly, this is the diagram of the motor work potentials. So moving to the next is the why TIVA. I've already told you the reason why we are using TIVA, because due to this neuro navigation, we have to avoid the muscle laxants, and we have to avoid the volatile agent as well, because more than 0.5% concentration of any volatile agent hampers the neuro navigation. So what are the different practices? I would like to have a comment from any one of the participants who are using TIVA for surgery. Can anybody like to comment on it? what are your techniques, how you are using TIVA, then I'll discuss, then I'll describe how we are doing it. Can any one of the participants want to comment on TIVA? Either they have used it or not? Okay, let me explain how we do it. We just go with the induction of the anesthesia with the routine like propofol, ketofol, or along with the muscle laxant. And once they apply monitoring, it usually takes 20 minutes after the induction, and then the position is made and the preparation is done. By that time, the effect of the muscle laxants are gone. So what you do is, what we do, ideally, the best combination is propofol and remifentanil. But obviously, we don't have remifentanil, so we have devised a different strategy. We go for ketofol infusion, and along with that, we use at times we use fentanyl when it is available, or we go with the Dexmed, because this is a surgery which requires deep anesthesia. And along with that, we are measuring our depth with the BIS monitoring. So generally, we keep it around 50 to 60, generally in that 40, 50, 55, in that level. And we just monitor it with the clinical sign like hypertension, tachycardia, and any other thing. If still there is a requirement, we can use the bolus of the propofol. And along with that, hypoxia, hypercarbia, hypothermia, and hypertension must be avoided in these surgeries. This I have already told you, so I'm skipping this slide. And these are the effect of different agents on the somatosensory evoked potentials. So fentanyl and remifentanil, these are the two agents which doesn't have any effect. Rest all have some effect on the somatosensory evoked potential. And ketamine, we are not sure, but what we are using ketamine in a very low dose, 0.1 to 0.2 milligram per kg. So we don't have any complaint from the neuronavigation team regarding the use of this drug in our practice. So wake-up test was before this somatosensory evoked potential. We used to have a wake-up test, and I'm witness to these as well when we started this type of surgery like 12, 15 years ago. In this, what we do, we just make the position before in the preoperative period. We before giving pre-medication, we communicate with the patient and we tell the patient that we are going to ask you to move your leg or to move your legs, and afterwards you do the routine induction. Once the surgeon has completed their job, what you do is they just tell you that you have to perform wake-up test like after 20 minutes. So that what we do is we just completely switch off our volatile anesthetic agent or TIVA or whatever thing you are using, and you just keep these patients on propofol boluses. And when they say do the wake-up test, then everything is switched off apart from oxygen, and then you ask patient to move the leg. So it is it works at times, but it works very nicely at times, and at times it doesn't work nicely. So with the availability of the this neuronavigation, things have become really easy. So managing awareness. Rationalized opiate administration, naloxone titration may be required later on. Use short-acting opiates and sedatives, and use in infusion form instead of giving them large boluses. Fluid management, you should go with the goal-directed fluid therapy, and then you need autologous. There are different strategies to manage the blood loss. Could be the autologous blood donation, normal volemic hemodilution, in which you just infuse a couple of liters before the induction of anesthesia. Then cell salvage technique, it can be used in center where the facility is available, and induced hypotension and use of tranexamic acid. These are the different modalities which can be used to manage the intraoperative blood loss. The common postoperative complications are, as I mentioned before, that pulmonary complications are the one because we are handling on the spine, and generally the vertebrae are involved from like 7 to 10 vertebrae involved. So it's major in CN, and there's an element of there's an element of pain, severe pain. So, so these patients, they don't cough. So ultimately they develop atelectasis, and later on may develop pneumonia. Scoliosis correction may prevent the respiratory decline, but rarely improve the baseline function immediately post-surgery. So this is an important point. And then patient with the vital capacity of FEV1 of less than 40% may require controlled ventilation in the postoperative period. And patient with the vital capacity of FEV1 of more than 70%, they usually can be extubated immediately. In our practice, we have hardly ventilated any patient. Even we deal with quite severe cases like angles of more than 70%, 80%. We are dealing routinely, but I can't recall hardly maybe 4 or 5 cases in the last 5 years which we have ventilated postoperatively. Postoperative atelectasis, hypoventilation, and opioid can worsen the pulmonary disease. So what you have to do is preparation of the chest prehand, and smart use of the opioids along with the other medicine if they are not contraindicated, and early physical therapy, and along with that breathing exercises, and the patient, they should be kept in HDU or ICU, and that's crucial for the effective recovery. But what we have done in our setup, that we keep this patient overnight in our HDU, and most of the time these patients are discharged next day to their wards. This is found in a paper. This is about a postoperative visual loss. It's a rare but serious complication following scoliosis correction, and the reason being that it occurs in the operation where patients are prone or in steep trunnion position. Basically, it is the long duration of the surgery, and patients are placed in the prone position, and the prone position is it's not the routine prone position; it is a steep trunnion position. And the two forms of the injuries have been reported. One is the optic neuropathy, ischemic optic neuropathy, and the other is the central retinal artery occlusion. So central retinal artery occlusion, it is basically the fault of the position, and it is from the direct compression. So you'll have to be very careful when you are positioning the patient in the prone. So you'll have to protect the eye with padding, and make the face is about to rest, like it's a head ring or it's a gel or whatever. There should not be any pressure on the direct pressure on the eye. So the other is the ischemic optic neuropathy, which is linked with the major hemorrhage, prolonged surgery, and intraoperative hypertension. So the other challenges which in the postoperative recovery are the chronic pain with a neuropathic component is common in the post-surgical post-surgery, because most of these patients they present due to pain. So they already have a neuropathic component, and it aggravates with the acute pain. And then PONV and inadequate pain control is the other important factor. So you'll have to take care of both of these components. So regarding postoperative ERA's overview, we must start with the multimodal analgesia, and early transition from the IV to the oral analgesics, and early oral intake, early mobilization, and if there are catheter drains placed, they should be removed as the need is over. Regarding pain management, we must opt for the WHO step-ladder pattern, utilize PCA whenever it is feasible, and depend what type of opioids are with you. We have the facility of morphine, pethidine, fentanyl, and nalbuphine and tramadol. But in most of the center, I know that we are left with only nalbuphine and tramadol. And the other things which can be taken care is the regular dose of the ketorolac and paracetamol. And again, if you're using NSAIDs, you should be careful about the platelet function and the renal function of the patient, along with the gastric symptoms. Start long-acting oral opioids on postoperative day 1 while continuing PCA if it is required. Patient to participate in the physiotherapy session, focus on the mobility and physiotherapy, and along with the incentive spirometry and deep breathing exercise, they help the patient too. So you can go for a single drug or you can use a combination of the drugs for avoiding PUNV. We generally use ondansetron along with decatron in the perioperative period. Now coming to the next challenge is this scoliotic patient and who's coming for the non-scoliotic surgery. So what happened is that they have anatomical distortion affecting the identification of the midline and the insertion level, and then increased insertion and higher rate of failure and complication. These are the problem when you're dealing with the scoliotic patient and you are trying for a sentinel rectal block. So leave this. In wide scoliosis, where you have an angle of 11 to 25 degree, you can proceed cautiously with good positioning. So you can attempt in without any additional aid. With a moderate scoliosis with an angle of 25 to 50 degree, consider paramedian approach, midline, or imaging guiding the approach, like you can use the ultrasound. If you are not able to attempt it in severe scoliosis with an angle of more than 50 degree, use imaging technique and consider alternatives. So these things should be kept in mind. So whenever you are using sentinel rectal block, you must look for the Cobb's angle prehand. What to do if there is pre-existing neurological deficit already present? It's a relative contraindication, and then risk of the further nerve damage or neural ischemia must be discussed with the patient and the family, and documentation of the neurological status is essential before and after the procedure. So another entity is the labor anesthesia, what to do for these cases. So controversy exists about the best technique. It could be epidural, single shot spinal, or a CSC, whatever is feasible. And it all depends from center to center and the personal experience of the physicians. So single shot spinal may provide adequate analgesia, and it is easy to administer. But what to do about the duration of the because a single shot spinal is going to give you analgesia for like 4 hours, but with the if you add certain adjuvant like dexmedetomidine or fentanyl, the duration may get prolonged. Challenges of the sentinel rectal block. Prior spinal surgery is not a contraindication, but it is challenging as the position is due to the placement of the rod. The flexibility of the spine is not there, so it is very difficult to make a proper position for the block. Anatomical changes due to the bone graft and screws can create scar tissue, and it is very difficult to identify the feel of the ligaments when you are inserting the needle. Scar tissue hinder and previous surgery can distort the epidural space, and distortion and spread of the local anesthetic leading to the patchy blocks. So even if you have placed the needle at the right place, you have placed the catheter, due to these previous adhesions, you may not be able to achieve the complete analgesia. Ultrasound can aid in identifying the epidural space in abnormal anatomy, and the benefits includes the improved insertion success rates and reduced attempts. But you must have experience with the normal spine before you proceed with this kind of spine. So common problems and troubleshooting are the patchy or unilateral blocks. Again, you have if you see this spine, and if already she has gone a surgery, so what you can do is, so how to manage this? You can reposition, you can reinsert the catheter, you can go for the CSC, or you can go for the single shot spinal, or if nothing is working, you can opt for the general anesthesia. Now, finally, this is the final component. This is the scoliosis surgery for the Russell-Silver syndrome, which I was telling you. This is a rare syndrome, and I have come across this patient for the first time in my entire clinical experience. It's a rare genetic disorder that affects how child's body grows before and after birth. Children born have low birth weight and they have congenital anomalies. It's a rare genetic condition that affects an estimated one in like 15,000 to 100,000 births. Dr. Henry was the first one who discovered certain features, and the Alexander Russell was the another one. So this is after these discoveries, it is named combinedly on this like Russell-Silver syndrome. So what is the mechanism? It is actually a genetic change in the chromosome 7 or 11, and which leads to the growth retardation. And in 60% of the patient, this condition prevails. However, in about 40% of the people clinically diagnosed with this condition, no genetic cause has been found. So clinical features to start with the intrauterine growth retardation, and they born with a low birth weight, failure to thrive. They have a short stature, low birth weight, and their size hardly grows. They have a large head size compared to the rest of the body. They have scoliosis. They have cleft palate. They have delayed closure of the soft frontinellis, narrow chin, triangular shaped face, and they have small jaw, microgentia, dental crowding, and downturned corners of their mouth, missing teeth, abnormally small teeth, and curved inward of the fifth pinky fingers, which is called pinky finger. So these are the clinical features. So the patient which presented to us was an 11-year-old male. It was a known case of Russell-Silver syndrome, and he was there for the scoliosis correction with history of kyphosis since birth. On examination, he had 90-degree thoracic kyphosis. His weight was 13 kilograms, and he had a height of 117 centimeters, 3 feet, and it's like 3.5 feet. His body mass index was extremely low. It was 9.5. He had a hemoglobin of 20.3 and platelet 399. He had a history of 3 days admission in the ICU on birth, and history of delayed milestone and late speech. But his intellect was fine when he presented for the surgery. He was born by the C-section. His sister was also known case of the Russell-Silver syndrome, and the patient had a cousin marriage. His echo was 71%, and his MET was more than 4. And structurally and functionally, his echo was normal. So this is the X-rays and scans of this patient before correction. You can see the curves here. This was his body habitus, and he was in extreme pain. And this is the X-ray after the correction. So they started their, it was from C4, I think it was from C4 to T10 levels. I'll brief you in a while. So what were the anesthetic concerns? It was an anticipated difficult airway, and there was a chance of malignant hyperpyrexia. So patient scheduled for C2 to T10 PSF, posterior spinal fusion, and the halo traction was plus minus. They said that they're going to decide if they want to put it later on. So we started with the monitoring, standard 1-2 monitoring, BIS, A-line urine output, neuromuscular junction monitoring, along with the neuromonitoring. Then we used propofol and etricurium for the induction. Maintenance was done on the propofol and ketamine infusion, and along with that, we used Dexmet, midazolam according to the infusion based on the weight. He was put in an arbor tube of 5 size, and it was done through the fiber optic bronchoscope assistance. Despite he doesn't show any sign of difficult airway, but we still prefer to use fiber optic bronchoscope. Later on, a bite block was inserted, BIS monitoring was attached, and he was the BIS was kept between 40 to 60. Foley's catheter was inserted. We maintained normothermia with forced warm air blanket, bear hugger, and warm ringer lactate, and dextrose IV fluid was given to him. He was put in a prone position, or pressure areas was assessed to make sure they are free of any compression. So this is the time to time X-rays which were taken during the surgery. And this is all about this case and scoliosis. So the forum is open for the
Thank you,
questions.
Dr. Jodat. Very nicely elaborated, very nicely explained. So before we can proceed for the question answer session, I will request Dr. Leena Aziz if she could please comment on this because they are also handling a large volume of patient in their hospital at Gurki Trust Hospital. Dr. Leena, if you are here, please.
Yes.
Yes, thank you very much. Assalamu alaikum. I hope you can hear me. We are dealing, alhamdulillah, on daily basis, at least 2 scoliosis patients daily, starting first shift and second shift. And we are doing with propofol and dexmedetomidine, mostly with this monitoring and all these monitorings which Dr. Jodat has mentioned. And we are also dealing with a very high percentage of scoliosis with more than 65 degrees, 90 and above. We are now doing 2 stages. We are using the helopelvic to these patients. And in the second stage, we then are doing the main scoliosis surgery. And alhamdulillah, it is very challenging as he explained it in detail. And the results are pretty good. And we do come across the long stay of the long surgical hours makes the recovery a little much more challenging than the induction time. And so far, we are using Dex with these patients, and whenever we have fentanyl freely at hand, we are using that as well. And so it's been really very good. So we have a regular basis scoliosis teams working on daily basis.
Thank you, Dr. Leena. So we have questions over here. Dr. Jodat, first question is, you have mentioned in your talk that a very few patients you have sent to the ICU. So is there any clear-cut indication in any patient in which we can decide at the time of surgery that this patient will definitely, we should send this patient to ICU?
So, well, it all depends on the preoperative status of the patient, number one. And number two is what are the cardiac and the respiratory component before the induction. Then how the surgery is gone, like at time, even with all these comorbidities, the surgery goes well and we don't need, but on the other hand, we can have a patient who has less comorbid, but they bleed profusely during the surgery. So it's a matter of like when you are dealing when you're dealing as like you take all these different components in account and finally you decide this because we try to optimize these patient pre-hand. So as I mentioned in my talk that we hardly send any patient to ICU. I don't remember more than 4 or 5 cases which were sent to ICU over the last 4 or 5 years.
That's great.
Dr. Jal, what is the angle which you are mostly operating on an average?
Madam, it is generally because it is, Dr. Durrani does it, and mostly we have referred cases. So it's generally it is more than 50 in general.
Also, so that accounts for the difference because we are dealing with a lot many cases, and as I said earlier, we go stage wise because if there are more than 90, 95, we go for the halopelvic first of all, and if it's a long surgery, we would prefer these patients to high dependency unit or in the ICU for a very, very close monitoring for these patients. So we generally do take care of these patients for 24 hours or so afterwards also.
Yes, exactly. What we do in our setup that if the angle is more than 70 or 80, they go in a stage wise, similarly the way you guys do it. And obviously that makes the patient outcome better instead of going for a huge and like heroic surgery to go for the stage wise. That gives you a better outcome.
Yeah, that's right. But the amount of hours which are being spent on an average on these cases, we feel more comfortable to be go in hand in hand with the ICU people and the high dependency setup. And Our teams are working with them 24/7, and the results are a little pretty good nowadays, alhamdulillah.
Madam, are you using neuronavigation in these patients?
Of course, you can't do without that. We definitely have the setup, and we do with the neuro navigation.
Okay. So Abdul Wahab has a question. He has raised his hand. Abdul Wahab, you can
Ji.
unmute yourself and ask the question. Abdul Wahab, you can
Sir,
unmute yourself.
can I?
What is the
Um,
what is the map to prevent spinal ischemia?
Sorry,
Yes.
couldn't hear.
Mahnoor
Regarding
Rahim is here. Please ask your question.
yes, sir, regarding induced hypertension intraoperatively, which is the what is the minimum map to prevent spinal ischemia?
You should not go less than 60. At
Okay,
time, I tell you that there are different surgical teams. There are certain people who would like to operate on a systolic pressure of 80 to 90, where our mean goes to like less than 50. But if you're dealing with scoliosis and major scoliosis surgery, you should not. You should refuse the surgical team to drop your mean arterial pressure less than 60.
okay, sir. Thank you.
Dr. Jodat, surely it depends on the average blood pressure of the patient to patient, and we should not go beyond 20% in any case, because as she mentioned, we have to maintain the vitals very stably,
Definitely.
and it depends on every patient. That 20% से नीचे तो आपने जाना ही नहीं है बिल्कुल भी. उसको तो pre op पहले optimize करें अगर blood pressure की इतनी problem आ रही है उसकी. It's not an emergency. It can be controlled. And I don't think so. These children, they're mostly the youngsters, teenagers who are coming to us. तो उनका ऐसा कोई मसला
Exactly.
होता नहीं, कोई मसला नहीं
Yeah,
होता. पहले ही आप उनको screen out कर रहे होते हैं, जिनकी congenital anomalies होती हैं. We have to see कि किसको इस वक्त कौन सी surgery की जरूरत है.
Exactly, because they're generally between the ages of 15 to 25, so generally they don't have a problem of high blood pressure, so they're
नहीं.
like hypertensive patients.
Dr. Jodat, Dr. Sovia here. Sorry to interrupt. I don't have the typing screen here. I'm on a mobile, so I just wanted to ask a
please
question
ask.
regarding
Yes, please.
regarding the TIVA. So you did mention you don't have REMI and stuff. That's why you put the ketofol and stuff in that. So does it make any difference? Because we usually here do use the REMI, and that obviously, and also propofol only TIVA as well. So we tend to usually use Schneider's model, and obviously you don't have REMI, but we use Minto model for that one. But when you're using ketamine with propofol and all that, how is your experience regarding that? Because do you still use the Schneider model, or do you use some other model with the ketamine? Because I haven't done it with ketamine, probably because I'm not used to it and I'm not comfortable doing that. And propofol only TIVA as well.
Okay, I tell you, because in Pakistan we don't have remifentanil at hand up till now, so we have to rely on whatever components we have with us. At times we have fentanyl with us, ketamine and propofol are always available. Rather, these days ketamine is absent these days from the market as well. So ये तो कहते हैं ना गरीबों का एनेस्थीसिया है. तो
नहीं, मैं सिर्फ ये पूछना चाह रही थी कि केटामिन यूज करने से या ओनली प्रोपोफॉल से आप लोग मॉडल चेंज करते हो, या you still keep using the Schneider model because it does affect the pharmacodynamics and whatever. जब आप combination बना लेते हो, are you guys still using the Schneider model, या आप उसको change कर लेते हैं अपनी ketamine के हिसाब से?
What we do is we take a syringe of propofol like 50 mils, and we add 50 mils, 50 milligram or 50 to 75 milligram, depending upon the weight of the patient. And then along with that, we go for dexmed infusion along with that. Because, when you are dealing with this surgery and you are going to operate on like 10 levels of spine, so it's a major incision and it is very painful. And without muscle relaxation, you'll have to have a very deep sedation level, so that the patient should not be moving during the surgery. And even with this kind of, like we're using like Domicum and Dex and along with the propofol and ketamine infusion, still patient, they tend to move. So you'll have to give additional boluses of the propofol as well.
Dr. Sobia, let me add here,
Sorry.
we are using propofol and dexmedetomidine as a general routine, and fentanyl, of course. We have fentanyl and we are using that. We are not using ketamine. Very rarely we use ketamine, but we are going that pattern.
Oh,
But
that's fine.
yeah, but
And just
overall now,
one more last point I wanted to make, because आपकी discussion was very comprehensive. It was touching every aspect of scoliotic patients and all that. Just a little bit, Dr. Jodat, I wanted to mention कि हमारे उधर पाकिस्तान में इस तरह का होता नहीं है, but should there not be a policy being placed also to deal with the emergency airway management in case of like scoliotic patients have also mostly being done in prone position and all that. और हमारी drills होती हैं airway emergencies के लिए, लेकिन कभी वो surgeons के साथ discuss नहीं होती because there is a whole team involved. Patient is in the prone position.
Sobia, I'd like to come in here. We do have these themes going on, and all difficult airway trolleys are ready. जैसे जोधत ने शुरू में ही बताया कि these patients are quite challenging. और इसमें अगर हेलोपेल्विक इनको लगा हुआ होता है, जो हमारे काफी पेशेंट्स को जो 90 से अबव को जा रहे होते थे, उनको हेलोपेल्विक से हम नीचे लेके आते हैं, तो उसमें तो देखें we have all the armamentarium with us. उसके बगैर तो हम स्कोलियोसिस में नहीं चल सकते, अल्हम्दुलिल्लाह.
Airway तो definitely
we have the difficult drills also going on.
Yeah, that was my point.
Yes,
that you drill
we do.
or either at least discuss that with the whole team before on the team brief. जब आप surgery सुबह schedule हुई है, and then the rest of the. But my point is the rest of the team should be aware what are the step 1, 2, 3. Yes, we lose the airway. This is what we do, and they are like drilled properly or trained for that as well.
जी, बिल्कुल, that is done. That policy is followed.
Yeah, and this is done
Dr. Jodat,
for all the patients.
I have one question. Okay, you are using TIVA and no muscle relaxant in drop. And have you any time faced patient movement? And
Yes,
if
we
no
do.
movement, you do. So what level of
Yes, we do.
depth you keep the patient in drop so that there should be no movement because patient is already prone position. And
look, as I mentioned that we try to keep our best level between like 40, 50. And when even with this, I told you that there's a possibility that patient might move whenever they are going into the deep dissections. So we'll just use the boluses of the propofol at that time. We ask surgeon to hold for a while. We just settle the patient, a little bit of the hyperventilation, a bolus of the propofol, and generally that's it. Because we can't use a neuromuscular agent during the procedure when neuro navigation is going on.
So you are increasing the dose of propofol?
Yes.
देखिए जी, जब neuro monitoring is being done continuously, so they are in a position to warn you right before the movement starts. और अगर थोड़ी सी भी होती तो वहीं पे आपको बीच में you intervene and the surgery goes on smoothly. There and then वहाँ पे आपको होता है कि जी the patient light हो रहा है या इसको अब आप देखें.
वो मैं आपको बताया था ना, एक पीछे एक डायग्राम में मैंने बताया था कि इट्स अ क्लोज कम्युनिकेशन बिटवीन द सर्जिकल टीम, न्यूरो नेविगेशन टीम एंड द एनेस्थीसिया टीम. सो वी आर ऑल इन अ क्लोज लूप. और जैसे ही कोई प्रॉब्लम होती है फ्रॉम द सर्जिकल साइड और फ्रॉम द जो न्यूरो नेविगेशन टीम है, वो आपको इंटीमेट कर देते हैं. सो जनरली वी डोंट हैव एनी प्रॉब्लम, बट एट टाइम यस द पेशेंट मूव. आई मस्ट
तो वो प्रोपोफॉल इंक्रीज कर लेते हैं.
हाँ जी, प्रोफाइल उसका बोनस दे देते हैं, डोज को ऊपर कर लेते हैं.
बिल्कुल.
Okay, Dr. Jodat, there is another question. Patient is surgery is done in the prone position. So how hypothermia is prevented? It has been seen that most of the patients they got hypothermic. Another question is regarding the post-operative pain management. Is there any role of regional block, peripheral nerve blocks?
Okay. Regarding hypothermia, we use Bayer-Hager as a default mode. So it is mandatory for all the patients who are going for scoliosis surgery. We use Bayer-Hager. And the surgeon, because we don't have a centralized like air conditioning system. So at time, we just manage the temperature from the inside of the OR as well. And if you talk about the
So this,
regional block in the
sorry to interrupt. So this forced warm air blanket, does it
blanket, yes.
interrupt the MEP or SSEP?
It has never been complained.
Okay.
It's never been complained.
Okay.
Now, regarding the postoperative anesthesia with the regional blocks, in our center, we haven't tried yet.
Okay. So
Dr. Liaquat has, I'm not sure about this because Dr. Liaquat has used erector spiny, but I'm not sure. I can discuss with him and I can get back to you for the.
Dr. Jodat, let me add here that it's an enormous incision on these are frail small patients. I don't think so कि erector spiny unless and until आप continuous उसमें कर रहे हो catheters डाल
कैथेटर
के
के साथ जी कैथेटर के साथ
जी कितनी देर तक उसको चलेगा unless and it's a small correction. If it's a massive correction, तो उसमें the multimodal anesthesia is what is being multimodal pain management is what is preferred.
They were particularly asking about regional anesthesia. So I haven't done it myself. Dr. Liaquat is involved in doing this, but I'm not sure what he's doing. But what I've heard is about
erector spiny bhi, I wonder, we'll have to ask Dr. Liaquat what is he doing because massive में top to bottom तक जितने कर रहे हैं आप जैसे आपने पहले कहा 8 to 10 levels are being done. So and they are usually frail patients. तो उसमें तो बहुत ही dilution के साथ आप 1 point दे सकते हैं मगर multimodal साथ आपको देना पड़ता है. तो exactly इसी तरह चल रहे थे and bear huggers and everything has to be done. Warm fluids, warm blankets, everything has to be added on.
thank you. So another question by Saida Ramsha. The question is, how can we manage the increased intra-abdominal pressure from Jackson frame?
From Jackson frame?
Yeah. This is our question. Jackson frame. Ramsha, could you please unmute yourself and communicate with us?
Assalamu alaikum.
Welcome.
Basically, my question was कि आपने बताया था कि जो prone position हम करते हैं तो private setups में Jackson frame available हैं जो कि patient के torso के नीचे आते हैं and they are used Wilson frame. Okay, sorry.
That's a Wilson frame. Actually, what जी मैं बताता हूँ आपको उसमें ऐसा होता है if you talk about the रमशा बोले आपका क्वेश्चन कंप्लीट नहीं हुआ
मैं यही पूछ रही थी कि इससे जब इंट्राब्डोमिनल प्रेशर बढ़ जाएगा तो हम उसको मैनेज कैसे करेंगे क्योंकि वो तो इंट्राथोरेसिक प्रेशर भी बढ़ाएगा ऑब्वियसली रिस्ट्रिक्टिव लंग डिजीज पहले से अवेलेबल है
इंग्लिश
तो
प्लीज
मतलब वो पहले से
इंग्लिश प्लीज
okay I was asking that in the patients when we are using the Wilson frame there is increased intra-abdominal pressure which also reversibly increases the intrathoracic pressure, so how are we going to manage that thing?
Okay, the Wilson frame, what you do is basically it is used for the heavy torso patients. So it is designed in a way that the abdomen is free to move. So it hardly going to it has less effect on the intra-abdominal pressure as compared to the other traditional things like the chalky setup which I was telling you, the big blocks. Because the abdomen is like, it is not free to move. But on a Wilson frame, it is free to move. Particularly if you have an obese patient with a hanging belly, this frame is nicely worked for them. It can be adjusted.
My next question was why 1% dextrose was given to the patient of Russell Silver syndrome intraoperatively?
Because he was a pediatric patient. He was 11 years old with just 13 kilograms body weight, and he had a NP of, because he was somehow got late on the list, so he had a little bit of the hypoglycemia. When we checked it was somewhere around 85 or 86. I can't recall the exact figure. So that's why we added dextrose in the ringer lactate solution.
Thank you so much.
So thank you, Dr. Jodat. Very vibrant session it was. I'm very surprised. People are so energetic at this time. Even it's about to evening time. So people are so energetic. It's very nicely attended session. We have our ex-General Secretary, PSA Karachi, Dr. Asma. If you could unmute yourself and give the closing remarks.
Thank you so much, Dr. Azhar, for coordinating the session, and thank you so much, Dr. Jodat. I was present in between, in and out, because of some commitments otherwise. So, but whatever I heard of from your lecture, it was quite practical, and I'm sure that you have been doing scoliosis for such a long time. So it was a good experience for learning experience for the residents as well. I'm also grateful to Dr. Lina that she has also shared her experiences because she has been doing a lot of orthopedic cases in her setup. And I'm really grateful to you on behalf of PSA Karachi to come online on a Sunday and also during Ramadan. So thank you, everyone, and have a nice Eid, which is coming up in the next week, inshallah. So we will be hoping to see all of you after Ramadan, that is in the Eid. So at Eid Mubarak in advance, everyone. Thank you so much.
Thank you very much. Thank you. Same to you.
Eid Mubarak to all of you. Thank you very much.
Assalamu alaikum.
Welcome, Salam.
Thank you, Dr. Jodat.
So with this, we come to the end of this session. Thank you, and see you in another session next month. Thank you.
Okay.